Well, let's go ahead and get started. We are so excited to be here with you all today. This is an especially fun webinar of our 10 for 10 series today because it coincides with National Nurses Week. So happy Nurses Week, everyone. We've kicked off today. Um, Today, we have some very special guests for you all. We have some of the nurses behind the Schmitt-Thompson protocols. So with us today, we have Cheryl Patterson, Courtney Book. Janine Fair is also one of the Schmitt-Thompson nurses. She is not able to be here today, sadly, but wishes you all the best. Kelly Massaro, Lori O'Brien, and Lisa Swearzak. So welcome, everyone. Again, we are so excited to have you all today with us. Just a little bit of housekeeping. If you guys, the attendees, notice there is a Q&A button down below. If you've got questions for any of the nurses, please feel free to drop those questions in the Q&A. You'll notice we have some of our team members here on ClearTriage support that they will be monitoring the Q&A for us. So feel free if you've got questions to drop those in. All right. Well, are we ready to get started? Okay, I'm so excited. So to kick us off, what I'd like to do, and Lori, if you are there, we cannot see you. I know your camera's working, so there we go, perfect. So to get us started, I'd like to just have you all share a little bit about your background so that our attendees can learn a little bit more about each of you. So why don't we start with, if you all want to share maybe a little bit about your nursing background, and then about your role at Schmitt-Thompson. So we'll just go in alphabetical order here, if that works for you guys. Okay, so to kick us off, Cheryl, I believe that you are first.
Okay, sounds great. Thank you, Kristen. Hi, everybody. So I've been a nurse for 41 years. And so the first about 11 years of my career was mostly inpatient. I was a junior nurse on night shift, so I got floated everywhere. So that actually helped me in my telephone triage career because I, worked in the nursery, postpartum, peds, ortho, oncology, lots of places. So that was helpful. I worked also a couple years in an OB clinic. And then in 1993, I joined our new call center at our hospital. I work in the Seattle area. And so had, of course, frontline nurse on the phones. And so I worked all shifts. I was clinical educator, program manager, QA manager, et cetera. So lots of roles in the telephone triage world and loved it, loved it, loved it. So in 2004, I started working for Dr. Schmitt and Dr. Thompson as a reviewer. And then 6 years ago, I have had the privilege of joining the adult editorial team and working with a wonderful group of people. So my role there, kind of the primary things that I do, I'm in charge of the client responses. So I sign those out to our team members. So I've probably talked with a few of you via email. And thank you for all that great input. And then I oversee a team of 4 nurses, and we review guidelines throughout the year. We get through about 155 guidelines a year. And so we're looking for current evidence-based practice, of course, making sure the guideline logic makes sense, and health literacy, and even things like typos and that type of thing. So that's a big portion of my work. And then also assist with new guideline development, and we have our clinical newsletters. So, and a variety of other tasks, but those are probably the main things.
Awesome. Thank you, Cheryl.
Sure.
Courtney?
Sure, thanks. I'm Courtney Book, and I am also a member of the adult editorial team. My background comes from emergency medicine. So I worked at a level 1 trauma center downtown Chicago for 16 years. And I had to beg for that position when I first started. I can remember I was one of the very first new grads they had ever hired in the ED. So I felt very privileged to be able to be in that role. So I was down there for 17 years. I was a manager, clinical coordinator, charge nurse, trauma nurse. We answered ambulance radio calls, all kinds of different certifications. And where my passion really was taking care of patients, as well as mentoring new grad nurses. I had a big pull for allowing new grad nurses to work in the emergency department. So I designed a mentoring program for them, and really enjoyed it. That is actually how I got to know Dr. Thompson. So I worked every Sunday and Thursday because my husband worked the other 5 days of the week, and Dr. Thompson also worked on Sundays. So we got to know each other, and I started just doing some work for him on the side related to triage, just because I had such a long triage background. And the working relationship flourished from there, and now I work solely for STCC. I love my role here. It is a bit of a 180 from what I used to do, but nonetheless, I find it very, very important. And it's actually helped me in a lot of ways. I write the adult care advice topics, so that is my head project right now, and I lead up that group. So if you have any needs for those, here's my plug. Send them my way, because I'm happy to help you, in turn help patients. And just like Cheryl spoke, we also develop guidelines. We do client responses, and we really enjoy working together. So thank you.
Absolutely. Thank you, Courtney. And I will I have an actual request in my inbox right now to send you on an adult handout. So I'll be forwarding that along probably
Love it.
later this afternoon. All right. Kelly.
Well, hi, everybody. Happy Nurses Week. And thank you for ClearTriage for inviting us all to speak. I'm very honored and consider you all very good colleagues and appreciate all you do every day on the phone. So I've been a nurse for over 40 years, which is frightful because I think I'm still about 30 and I don't know how to compute that in my brain, but my clinical experience and background is mainly in peds ICU, where I worked 14 years as a clinical coordinator and in various leadership roles but in 1996, I started at our call center at Children's Hospital Colorado as a triage nurse and did calls throughout my 25 years there and ran their QI department for about 10 years there. And that's where I met Dr. Schmitt. And as some of the other nurses alluded to, I started working for Dr. Schmitt on the side, just doing some proofing and kind of refining guideline content and things like that. And then we would use our QI results to tweak the guidelines. So it became a very mutual beneficial partnership. And in 2005, I started actually doing the database entry for him and kind of overseeing the whole clinical content of all his content sets. So we've been working together for over 20 years now, and it's been a very good partnership and teamwork. And, all these ladies are part of it. And can't thank them enough for all the support that we get. And from users like you, I really appreciate all your feedback. And so that's about it for me.
Thank you, Kelly. Lori.
Yeah, welcome everyone. Like the others, I'm proud to say that I'm a registered nurse. I started my career as a burn nurse, and I have some disease management and ICU experience as well. Similar to Kelly, my role in telehealth triage started in 1996, and I think probably our paths and Cheryl's path are very similar in that we have over 30 years of telehealth triage experience. So I'm sort of mentally calculating in my brain the collective telehealth triage experience that this group has, and I think it's going to be probably close to well over 100 years, which is incredible. So it was early in my career that I started in telehealth triage. Most recently, I served at the University of North Carolina Healthcare System as their director over our RN telehealth triage team there called Nurse Connect. We covered primary, specialty, and some urgent care teams. We covered over 200 practice locations. and I transitioned out of that role in March. I have also been involved with a group called the Patient Access Collaborative. This is a collaborative learning network of academic medical centers, mainly focused on access, but because telephone triage is often a part of those teams, there's a focus on telephone triage within them as well. And we're getting ready to have our annual conference next week in Houston. So that'll be a lot of fun. But when I transitioned from the University of North Carolina, I expanded my role at STCC. So after 5 years of being a clinical nurse analyst reviewer, I have now assumed a nurse editor role. So Cheryl and Courtney did a great job of outlining some of those duties, and I support them as their point person, sending me care advice topics or guidelines for review. Part of my focus is on a new area, the creation of a digital health work group. And really what we're going to be doing is finding ways to improve that telehealth triage process. So can we use technology to maintain the quality and safety that we're all accustomed to, but improve that triage efficiency? So that is really an area I'm excited to explore. So there'll be more to come in that in the future. And that's me in a nutshell.
Thank you, Lori. Okay, last but not least, Lisa.
Yeah, hi everyone. Yeah, and happy Nurses Week. This is awesome. It's an awesome way to connect with some of our frontline triage nurses, because I think I'm really proud of the job that we do. I think it's really hard when our protocols are absolutely invaluable, yet there's so much to critical thinking and our keen listening skills to get these patients to the right place at the right time frame without ever laying eyes on them or being in person with them. So I think we do an awesome job, and yay us. As far as background goes, like everybody else, I started when I was 12, and I just celebrated my 38 years at Children's Hospital. That is where I've spent my entire career. A large part of it has been spent in telephone triage, various roles, clinical and administrative. What's a little bit unique about St. Louis Children's Hospital is we do have an advisory board that meets about 6 times a year. It has specialists from ID, emergency rooms, sometimes pulmonary, physicians from Washington University that also attend the meeting, as well as our community pediatricians and our triage nurses. And so with the advisory board meeting, I gave lots of feedback to Kelly and Bart. We've been using Dr. Schmidt's guidelines since about 2002. And so, yeah, we became pretty tight friends and giving lots of feedback. And so the past 6 years, I've had the pleasure and great honor to work with Dr. Schmitt and the pediatric editorial team. Like Cheryl, I usually am the first person that gets some of the feedback that you all provide and help decide where that goes next. So we welcome your feedback. Thanks.
Wonderful. Thank you, Lisa. Well, thank you guys for all sharing a little bit about your backgrounds and your roles at Schmitt-Thompson. I also love that we are allowing nurses to connect this week on Nurses Week, the faces behind the emails and all of the wonderful work that you do. And Schmitt-Thompson really has assembled an incredible group of nurses, and we are all so lucky to have you guys working on these protocols. And I'm sure I'm speaking for a lot of folks that are in the attendee list today as well when I say that. So to kind of get this conversation going here today, I've got some questions for you guys that I think will help to kind of elaborate a little bit about your roles and what it is that you do. And again, there is a Q&A below. So I know that there are a couple of questions in there already. We will answer some of those questions. We'll save some time at the end to go through some of those questions as well. So if there's anything else that comes up attendee-wise, if you guys have questions, please don't hesitate to drop those in the Q&A, and we'll try to get to as many of those as we can at the end. Okay, so this question is for you, Lisa. How do you and the team decide when to update or revise a protocol? And after you kind of share a little bit about that, do you have any examples that you can share, a recent example that you worked on?
Sure. As we said, we rely a lot on feedback from our users, after hours users, office hour users. That is one of the ways that we decide what to revise or what would be new for development. Also, as we all have experienced, if there's a outbreak such as COVID, certainly lately it's been the measles protocols that have been given more attention because of what's going on in the community. As far as when we get feedback from our frontline users, we think about, are these high volume calls? And then we also think about, are there high risk calls? Meaning if there's inaccurate protocol information or that would somehow pose a safety concern, those obviously escalate to top of our list as far as needing a revision or generating a new protocol. We also look at the no protocol data. If we hear back from multiple offices or call centers that we're missing a protocol, there's a need for a protocol, and because there's not a protocol available, we have to use the no protocol. So we do look at that data as well, and we track requests for any specialty guidelines, and we follow that. So it's always helpful to know from our users if you're on after hours content or office hours content or both, and whether it's a question for the pediatric protocol or the adult protocol or both. Also, it's always helpful to know recommendations or what protocol was used. It may or may not be helpful to have some call details, obviously no PHI, but if it's, the age of the child or the outcome, we're happy to know that as well. And as far as an example that I have worked on, this actually came from a ClearTriage office, one of the offices that uses ClearTriage, and it was in regard to bat exposure. It's kind of interesting, and it prompted some research on the pediatric editorial team side, and Dr. Sam Wang, who is an associate medical editor for the pediatric side, was able to consult with animal control, and we made some changes in the triage statements, as well as some new care advice in regard to how to handle bat contact and exposure, and at what level those patients need to be seen. And a couple of the new triage statements also deal with how you handle a bat, whether it's dead or alive or in your dog's mouth, which has happened. I think I've received that call. Yeah, so that would be a recent one.
So feedback is important.
Exactly.
Okay. Adult team, is it similar for you guys as well?
Absolutely.
Okay. All right. Well, Kelly, if you don't mind answering this next question, how do you make sure that the protocols reflect current evidence and best practices?
Well, I think there's several ways we do that. Annually, we do a pretty extensive lit search. So if you've noticed your reference list coming out every year when we update the protocols, I think this year it was about 50 pages long of new references that were added. So we do pretty thorough research about what's new in the last year and to see if it impacts the guidelines as far as treatment or triage indicators. So we do some review of that, and just an example of that would be this a recent article that came out about respiratory rates in febrile children, that there's kind of this misnomer that fever impacts and makes a respiratory rate higher in children. And this study totally disproved that and looked at a number of children. And so what we did with that data is we just revised the background information and put, made it stronger in the background information that tachypnea is usually lung disease until proven otherwise, or a metabolic disorder like DKA or something like that. So we made the language a lot stronger. So that was an example of an evidence-based practice research that proved that it doesn't have anything to do with the respiratory rate in children. So and then I think another big piece of it is QI studies. We do a lot of QI studies at our call center at Children's Hospital Colorado that look at outcome data. So when I participated in some of those, looking at, we might pick a particular triage indicator and look at outcome data. So dehydration or, high respiratory rate, we might find out, we might pull 50 calls that use those indicators to send kids in and see what happens to them. So that allows us to kind of tweak the guideline. If it's the guidelines error, not specific enough or precise enough, we might tweak it based on that. The other thing we do is a 24-hour outcome study that actually looks at kids that are hospitalized within 24 hours of a call. Then we go retro back and in the last 24 hours and see if we had a call to the call center. And then we usually listen to those calls to see if there was an indicator that was missed. If there was, we kind of tweak the triage questions based on the outcome of that call. So it's based on data and evidence in that particular instance. As Lisa mentioned, we get a lot of feedback from call centers. We get call center feedback from nurses and physicians, not only in the US, but Canada as well. So we solicit that annual feedback from probably 25 major call centers. And then we get call center feedback throughout the year from, maybe somebody who doesn't contribute annually, but any kind of questions that they have, we answer. So that also helps allow us to tweak and refine the guideline content. We also use UpToDate if there's any kind of question about, if we're practicing standard of care, we'll do a little bit of research to make sure that we're still up to date and current with the current proposed treatments. The other thing we do is collaborate a lot with the adult team. And so if there's the adult team is making changes, they'll send it to us. And likewise, if Pete is making major changes, we'll send it to the adult team so that we can provide in sync, correct, up-to-date evidence that our protocols are correct. So I think those are the 4 or 5 main ways that we do that.
Yeah, that makes a lot of sense. And speaking of feedback from nurses, Cheryl, what kinds of questions do you guys receive from triage nurses? And what's the process? How do you go about addressing those questions?
Yeah, great question. Thank you. And I'm going to build a lot on kind of what Kelly said. We receive lots of great questions and feedback. And really our aim, of course, is patient safety, but also to support the triager so that you guys have a tool that really helps you in your role. We've all sat in the chair and been on the phone, and so we want to make really great tools for you guys. So lots of a variety of questions, guideline related. So perhaps maybe a logic question. So maybe a guideline, and we're going to use the term guideline or protocol interchangeably. So you hear both terms today, but maybe a guideline will refer a triager off to another guideline, and maybe that's in question, or there's a loop or something that doesn't quite make sense. So we get questions like that. Specific questions about a triage question, or maybe could you add some care advice? We get guideline requests. So maybe a new, symptom that's come along, or where in the guideline set would you find this particular thing addressed? So we get questions like that. We even get some QA types of questions and some orientation types of questions. And so really the whole gamut. And then several times we receive even typos or duplicate words. So it's all good. We appreciate all that input. As Kelly said, we try to align when possible the pediatric and adult sets. So if there's something, if someone has a question about the peds chickenpox guideline and the adult, we try and collaborate and make sure that we align as much as possible between the content sets. So that helps the triager with the continuity. And on our responses, sometimes they're very straightforward, and so we can do a quick turnaround. And then other times we need to dig a little deeper and do some research and maybe collaborate within the team or amongst the two teams. And so those responses might take a little bit longer. Kelly has been instrumental in working on the content for the user's guide. And so if you're not familiar with that, that comes out every year, and you would talk to your software vendor to get that. But there's a lot, just really a wealth of information, really for frontline triage nurses and call center leadership. And so if you don't know about that document, ask your software vendor. But a lot of our responses, we will take and build off the principles that are in that user's guide. So we might just use a little clip from the user's guide and then kind of tailor the rest of the response to whatever the specific request is. So you might see some information from the user's guide. Again, great document. Let's see what else. I think Lisa mentioned patient information. The call details is very helpful if it's something specific to a call. And some people even send screenshots of maybe the triage question that's in question that might need clarification. So that's all really helpful information. I think that's about what I can think of for right now.
Yeah, no, I think that's good information to have. And I personally always appreciate your responses, everyone's responses to nurses when they do have questions. If you've ever communicated with Cheryl or any of the other team members, you know that you guys provide very thoughtful responses and feedback, and we all very much appreciate that. Okay, so switching gears just a little bit, my next question is for you, Courtney. How does your own clinical experience or the clinical experience of triage nurses in general, how does that influence the way that you all help with that protocol development, or maybe in your case, handout development? How do we see any of that? How does that work together?
Sure. So again, my background is in emergency medicine. So I don't have a strong background in telephone triage, but the art of triage itself doesn't waver. So we, even as training, new nurses in the ED on how to triage patients, it's very intimidating when you're a new nurse. So scaling back those same principles of symptom severity, duration, and being able to develop protocols from those standpoints. I also think it's a privilege in this role to be able to have the experience that I have in emergency medicine, just with the specialties that I have seen that come through the ED specialty patients. So you think of your urology patients, your oncology patients, your pulmonary patients, heart failure, the many different disciplines in the ED that we get to see and actually interact with some of those specialists is a great asset as we develop protocols. So I also think, it's a privilege to be able to take on the role of both the patient and the clinician as we develop these protocols. So very vividly seeing patients who are in the midst of an emergency, and that vulnerability, I think, drives some of those TAQs. You have a patient that's acutely worried about this blood pressure or this fever. So that's one area where I really feel like my background in emergency medicine has been great. And I definitely think that I draw from that experience. In the realm of care advice topics or patient care advice topics, Specific to our callback if statements that are in the patient care advice handouts, I had the luxury of working in an ED or triaging patients in an ED with other nurses, and the patients were in front of me. But we did not use standardized protocols. So where I may have triaged a patient one way, a nurse down the way may have triaged that patient completely different. So I think this has brought such a well-founded respect for standardized triage, especially, thinking of the IAQs and how we develop them. Those are just a couple of general thoughts, but we used to have patients who would wait in the ED, as you can imagine, and I'm sure many of you have experienced, there's 40 patients in the waiting room and they come out for one bed. They have one bed. So even making that clinical decision among all of those ED patients, which one is the one that you send back? When I would triage patients, I would tell them, similar to a callback statement, if your condition worsens, if you notice A, B, or C, I want you to come up to me and let me know. Even though they're in front of me, I still couldn't get them to the care that I felt like they needed at that point in time. So being able to circle back around with them and give them that comfort of knowing that I'm here, you can come back and reapproach me if things change. I also find that that's the language that we wanted to convey in these care advice topics.
I love that. I think as nurses, we're all part of our role as nurses is educators. We're all educators. In every patient interaction, we provide teaching and education. And I love your response to that. Okay, Lori, what is one thing that you wish every triage nurse or every nurse understood about the protocols or telephone triage in general?
Thank you, Krista. I really love this question. And I'm going to lean in mostly on what I wish others knew about telephone triage in general, because I think my fellow STCC teammates here would agree with me that those of us who have like 30 years of experience, we've seen a lot of change in this space over the last several decades. And largely that is the standardization that has occurred with guidelines being available. So the consistent evidence-based approach has really driven the recognition of telehealth triage as a professional means to deliver care. And I think that's something we can all be proud of, but it wasn't always that way. The other thing that I know that has changed, at least in my career timeline, is the patient populations that we serve. I think telephone triage largely had its birth with pediatrics, parents calling about their children who were sick, and there was a recognition of the value that telehealth triage provides. And I think more teams now are serving more complex patients with nurse triage. So that's adults with chronic conditions, specialty patients, urgent care areas like that. So I think when I thought about this question here, I think my wish is that telephone triage becomes recognized as that highly specialized skill set that it really is. The complexity and the nuance that our teams face, that all of the folks that are attending today, whether they're working in a centralized nurse triage group, where they might be triaging patients across an entire healthcare system, or maybe they're just getting calls from birth to geriatrics. That's complex. Or maybe they're serving multiple specialties, right? All of this requires critical thinking. It requires making some difficult decisions. And kind of like Courtney talked about, triage for outpatient telehealth triage is very similar to ED triage. The reasons patients seek care is really varied, and you have to make a decision swiftly. So the other thing I would say is that nursing really helps patients buy in on the recommendation, right? We've all told patients they need to call 911 or go to the ED, and they might be scared or reluctant. And getting them to buy in on what they really need to do, that takes trust, right? It takes a lot of skill to get patients there. We all know that, but sometimes that's forgotten by others around us who maybe aren't in this space as much as we are. So I'll just end by saying that I think our job here is to ensure that we create awareness of what telehealth triage is, and really the patient-centered care that it provides. And I think it's only going to continue to evolve.
All right. Okay, my last question, and this is just for the group, is what's something that the attendees today might be surprised to learn about how protocols or guidelines are developed?
I can begin by sharing one thing that I found as I started is that we as nurses actually begin and develop protocols as well. So this is not something that doctors develop and then we review. It's as nurses, as the frontline triagers, we are the ones that develop them, and then they go through the physician editor process. So I found that that was really, in my opinion, just an asset to being able to take the bull by the horn, so to speak, and just kind of start that protocol and develop it from the perspective of the nurse. That's one thing that I thought was pretty interesting.
No, that is interesting. I'm not sure that I was even aware of that. So, yeah.
I think our process might be just a tad different. You know, I think if we're starting a new protocol from scratch, the physicians usually take the first draft of all that and then they pass it back and forth. And then as they fine tune it, they'll pass it to the nurses to review, and we'll make sure that it works from a triage point of view. Certainly, I think one thing people would be surprised at is the amount of time it takes to develop a new protocol, because in my experience over 20 years, if we're starting from scratch and building a brand new protocol, it probably takes 2 to 3 months to refine that protocol to where we get it up and running to where we think it's going to work. And we involve a lot of reviewers. We involve nurse reviewers. We sometimes will involve the adult team if it's a full service protocol that impacts the adult population as well. And we'll involve subspecialty reviews if it's, you know, something that generalist pediatrics aren't familiar with, such as sickle cell or a tonsillectomy guideline. You know, we'll involve those subspecialties to review. So it's just a multi-layer process and review process to get it even up and running. And then we'll send it out to review to maybe, if we have time, to trial in a call center, to make sure that it works before we release it to the all our subscribers. So
that is definitely interesting. Okay, well, should we dig into the Q&A a little bit, because there are some good questions in here. It looks like our support's been answering some of them, but let's see how many of these we can get through. So I don't know, you guys probably can see these if you open the Q&A, but I'll go ahead and read these questions out. And if it's something that would require a longer response, feel free, STCC team, to let me know that would be a question better answered with a follow-up email, and our support team can get some contact information from that person then to allow you to respond in email. So, okay, this question is to Courtney. This is one of the questions our team has. What tips or resources would you recommend for behavioral and mental health triage for nurses?
Wow, this is a complicated one. So we do have protocols that are specifically designed for mental health. Just as you triage other related disease processes, I would again just really encourage you to go to your symptoms, hallucinations, tremors, suicidal or homicidal ideations, anxiety, depression, whatever those that patient's chief complaint is. I would really hone in on what specifically that patient's calling about. And again, as nurses, you know, we recognize that mental health is something that doesn't come in a boxed form for certain. And there is obviously multidimensional triage sometimes even involved there. Sometimes it's having to look at two protocols. And so those would really be some of the top things that I would recommend to start with. You know, it's a fragile patient population. When in doubt, your nursing judgment skills are going to come into play all day, every day with this population of patients for certain. So.
Okay, great answer. All right. So then we have another one here. This person says, Happy Nurses Week, everyone. My DON wanted me to ask if there's a quantifying tool to measure triage productivity. So I don't know if any of you have an answer for this one.
I can jump in and at least start. I was recently in this operational space where this is a really challenging thing to answer. A lot of what's measured with telephone triage, I think, has to do with transaction or the service, right? How many calls are you doing? How long does it take you from start to finish? And those are important, and we do need to measure those. Where there might be a gap, though, is that telephone triage teams often do more than just triage. They might be doing in-basket messaging. They might be doing care coordination. They might be escalating those calls for second-level triage with on-call providers. You know, they might be making appointments. They may be looking to see for that behavioral health patient that Courtney was just talking about. What resources can I get them to at the time I'm taking this call, which for many is after hours, where resources are more limited. So I would say the answer to this question is that those metrics are really important, but they don't tell the whole story. I think patient stories are super impactful. I think patient satisfaction, to the extent that you can measure it with telephone triage, helps with some of this. But taking the number of calls per hour and simply doing a calculation to see how many nurses you need for that particular time frame really misses the mark. And so I don't know if others have anything else they want to add to that, but that's my take on that.
Yeah, one additional thing I can think of is if asking, you know, original inclination or what were you planning on doing and comparing that with the disposition. So at our organization, we shared that with our upper leadership. We asked that question of patients, what were you thinking of doing if you hadn't called us today? And then we had a comparative report to the actual disposition and said, you know, so you see people that either would have delayed care, which is more costly, or didn't seek care when they need to. So, or rushed in and they didn't need to be there. So that was another metric that we shared with our upper leadership.
Okay. So this next question is actually looks like a couple of questions in one. But let's talk about the first one. So while we recognize the importance of Schmitt-Thompson protocols, what role does critical thinking and clinical judgment play in ensuring effective triage nursing?
I love that question.
Yeah,
I'll jump
I was
in
gonna
if
say, I
somebody
get
else
the
wants to. The educator part of me just, yeah, gets on that. But I used to, when I was in the educator role, I would say, you know, so really the guidelines are sort of the scaffolding, or they're the bumpers on the side of the bowling alley to keep you safe. But you can't just have a person that's untrained to get in there and just read through, you know, A, B, C, D and follow it down that way. And that's where registered nurses and higher really need to be in this role to use all their clinical expertise and the guidelines together to come out with the correct disposition. So that's such a great question. You can't just only go with the guidelines, and you can't only just go with the your clinical knowledge, because you might be a knowledgeable nurse, but nurse B might share something a little different. So the combination of the two is what's really important. And I'm sure my colleagues have other things to add.
Yeah, I might also add, I think that's a really great question because I've always been an advocate for the nurses making their own decisions. You know, the guidelines are a decision support tool. They don't make the decisions, the nurses do. So, and you have to kind of incorporate all the information into your brain. And I think I saw somebody ask about AI, and I just hate the idea of AI taking over for nurses because I don't ever think that an AI machine is going to be better than a nurse processing all the information personally. But the other thing is somebody mentioned the clinical newsletters. I wrote a clinical newsletter about critical thinking and how important it is in the triage processing and making decisions and making accurate decisions. So I think it's super important, and you cannot minimize that um, aspect or ability of the nurse to do that despite using protocols. I remember when I first started in triage, I thought, oh, how hard can it be? You just follow a protocol. Oh my gosh, you know. But every call is different. And, you know, somebody throws this nuance in and you're like thinking, well, that sounds weird. You know, so I always coined it as the sounds weird to triager because you know, if something doesn't make sense, it's probably not right. And, you know, somebody using AI or somebody, you know, if you don't take that into consideration, you're going to miss something. So I think it's really important to maintain that critical thinking. And I think it's probably, you know, a very, very high priority in training new nurses and things like that.
Yeah, and I'll just piggyback on that to say that one of the first decisions the triage nurse needs to make before they ever get to a protocol or guideline is, which one am I going to choose? What's most applicable
Right.
here? What is the most acute symptom that I need to focus on? So that happens before you even open a guideline, and then it's supported with the guidelines throughout the whole triage process. There's decisions that are being made.
Yeah, and I feel like I said that at the beginning, like having Nurses Week, because I do feel like this is a really challenging job because we are not in person. And as far as AI, if it's like a really straightforward call, I could see it working a little bit. But most of our calls are not straightforward. And we take in the background information, and the mom, from a pediatric perspective, the mom may be telling me that the baby's breathing fine. But if I hear the baby with intermittent grunting in the background, like, eh, eh, I'm like, wait, is that the baby? Can I listen to the baby? Or even when we ask the parent if they're comfortable with the information that we've given them, if there's like a hesitation and a delay in them quickly responding, or I sense they're not confident, then that requires more attention that AI cannot provide that. So we could go on about this, but I know we probably want to get to other questions.
And to follow up on that, because there was another question related to AI, and as you guys can probably imagine, that's been a kind of a hot topic in a lot of these conversations, and it's something that continues to come up in the Q&As of these conversations. This question is also around AI, but a little bit different. So with the use of artificial intelligence growing in various fields, do you feel AI will have a place in RN triage? And if so, can you share some ways that RN triage might be embracing AI? So maybe not necessarily taking over, but are there other, you know, ways or areas that you guys could see that working, or things you've heard?
I can start really quick. I know that one of our convenient cares where they see pediatric nurse practitioner providers, they go through, before you're able to book an online appointment, there's a series of questions that you have to ask. And is your baby having breathing difficulty? Or I'm not sure what those questions are. But again, it's an attempt to screen out, your baby needs to go to the emergency room. Please don't book an online appointment at a convenient care. So that's one way that I see AI creeping in initially in that in that venue.
Yeah, and I'll piggyback on that a little bit here. Just like telephone triage had a surge, back when the electronic medical record really became much more prominent. With AI coming into the space, a lot of providers are using AI for note tool creation, for documentation support. And so there may be ways that we can make things a little bit easier, more efficient for the group that does this work really well, the nurses, by providing some efficiencies with AI. But I think there's a lot to learn. I think we don't yet know how healthcare systems are going to approach this from a legal or compliance or risk perspective. So even if those tools exist, we have to see what happens with regulation and cost and all of those other areas that are somewhat unknown. But there's definitely an interest in seeing how AI can support all areas of healthcare. So I think there's much to learn.
And I'll just kind of quickly add too. I know this is something that probably many vendors are thinking about, us included. And Dave and Pete, our founders of ClearTriage, are doing one of these webinars in July, and I think that is their topic. So for everyone that's interested, or one of the topics they're going to discuss, if anyone is interested and wants to sign up for that, that might be a place to get some more information. Okay, so let's transition out of AI. This next question is, has there ever been a discussion on having rural versus urban as an additional separation, similar to office hours versus after hours, since the resources differ so greatly and affect dispositions? I don't know if anyone.
Well, I will say, from my perspective, which have been around for a while, no. But I think what we do allow is customization of the guidelines based on your local resources. So for instance, if you're a nurse triaging in Craig, Colorado, who's, a town of, and I'm sorry, I'm not going to quote this right, but 500 or 1,000 people, you don't have the same resources that an urban city would have. So you may need to tweak the guidelines a little bit and customize the guidelines based on your local resources and what your, what those ERs are capable of doing, because it varies a lot. And same with rural Canada. We get this question a fair amount, just based on, where you live and the resources available. So you need to make those decisions based on the locale and what is available. But as far as I know, there has never been any discussion about doing a separate database set for particular rural counties. But you guys can chime in if you have additional thoughts.
Yeah, I think the disposition has two components, right? There's a time frame, and then there's a location or level of care that's recommended. And I think this is yet another one of those nursing decision points, which is the time frame is pretty set, but the level of care takes into account what's available in your area. So that triage nurse is going to be looking at what level of care is equivalent that's available in my area for this particular patient that I'm serving. I think it would be very hard to separate the content set out based on rural and otherwise. I think largely it suffices to do that. It's just operationally, or the team thinking about, what is available and where am I having challenges getting patients to care. Often that just means emergency room is the only thing that's available.
And I think just one.
And you also have to kind of work with the caller to see, how far away are you? Are you 3 or 4 hours away from the ED? Or, like Lori said, sometimes that's the only option in a rural area. You have to get in the car and you have to drive because there's, volunteer 911 services, or, you just have to kind of work with what you've been given. And so the triage nurse kind of individualized that plan of care based on the local resources available and what is needed for the child or patient.
And so I was just going to add on some of the care advice actually gives the triager several options, and it says, you know, hey, consider. And so again, you would take that into consideration with what's available in your area. And another thing you can, as Kelly mentioned, customization of guidelines, or you can also handle that with a policy. So if you say, hey, anytime you come up on a C in 4 hours and we don't have an urgent care, but we do have this clinic that could see patients urgently, you could say, when you reach this disposition, that's an option for you instead of customizing all the guidelines. So that's another alternative to handling something like that.
And we support customization in that regard of the actual dispositions and also the disposition guidance. Customization, that can be a really nice way to add some of those nuances in there as well, I think. So, okay, how about one last question? Because I know we've gone over, but we still have a lot of folks on this call, as expected. So one more question, and then to those of you who've put questions in that have not been answered yet, if you would like to send us your email, that way, because I know some of them are anonymous, that way we can make sure that to follow up and get those questions answered, that would be great. Okay, so we'll skip down to the bottom a little bit. How many years of experience do you think a nurse should have to be a telephone triage nurse, and what background?
It's a great question. Okay,
Go ahead.
go ahead, Courtney.
I don't think there is a set number of years for experience, nor do I think that there is a set background for experience. I think, you know, just as I mentored new grads in the ED, I think it depends on their triage, you know, their orientation process. I think that what that looks like, their onboarding, you know, you think modules, different education activities that are going to support them as they fill this new role. I don't think there's a one size that fits all. I would argue that potentially an experienced nurse may struggle with the same difficulties as a brand new nurse, and an experienced nurse in a particular field. So if you're thinking me as emergency medicine, coming in as a telephone triage nurse, I think I would experience different challenges or difficulties than potentially a new grad nurse would experience. So I think it's all in the way that you shape and mentor that nurse, as well as provide them a great runway to be successful. So looking at orientation and onboarding programs, learning modules, call review, I think is another one. That would kind of be my thought with respect to that question.
Great. Well, thank you guys again. Thank you so much for joining us today. This has been a great conversation. And again, happy Nurses Week to everyone. Our next webinar is going to be with Julie Ortiz. She is the president and founder of Triage for Pediatrics. And we're going to talk with Julie about the founding and building of her company, Triage for Pediatrics. So that will be on June 12th. You can register at that URL there, cleartriage.com/10for10. If you have any additional questions, and again, if you've got questions in the Q&A, we'll try to pull those out and get those answered if we've got contact information. But any other questions after this, you're welcome to email us at ClearTriage, support@ClearTriage, or we've also put the pediatric and adult editorial teams emails on this slide, so you're welcome to send them emails directly. They've kindly offered to take any questions after this in those inboxes. So, all right. Well, thank you guys so much. This has been a great conversation. Really appreciate you all. And again, happy Nurses Week.
Thank you.
Bye, everybody. Thank
Thanks.
you.
Bye-bye.